Well, good afternoon. Good to meet all of you. And what I'd like to share with you is something I've been thinking about, working on, and planning for our institute, which focuses on children with broad spectrum of neurodevelopmental disorders. And we serve these children, and so we have experience with this as clinicians, as therapists, as teachers, social workers. We have our own school. It goes all the way through high school. We're not advocating many children come to our school, but we're trying to figure out the best way to educate and support children with neurologic disabilities and the behavioral issues that come with it, which is often the case. And so I'm going to tell you just a bit about how I see the future, but I wanted to start showing you when we examine a child and make a diagnosis of dyspraxia, what are we really, how do we do this? And I'm talking, what I'm going to show you relates to motor dyspraxia. And what dyspraxia means, or apraxia if it's an adult, that you have the innate ability to move, strength, feel, your coordination as we test it is all okay. It's when you try to put it all together into a bigger act and imitate people, imitate motor activities, that's where it falls apart. And it falls apart because of higher order connections that are not just right in terms of these coordinated activities. And as you've heard, it doesn't have to be just motor, but the motor is the easiest to see and the easiest to quantify. So if we're looking for therapy or prevention or impact, we can measure that easier than we can measure other things. So, and we actually have two of our clinical scientists who are particularly focused on dyspraxia. And so we know this entity. And so I want to show you the end examination. The first thing I would do, have the child walk, have them do different things, hold their hands out, finger to nose, and all that they'll do. Here's what they won't do. And let's see if I can make it work. I think I have a minor version of this, to tell you the truth.
I think most people in Hollywood have a minor version of this.
Okay, meteor cannot perform to a tested action after this time. That's when you're here.
Yep. We'll just restart. Oh, there's Megan's little baby.
There's no sound. So what this child who's neurotypical, meaning doesn't have one of these issues, is being asked to imitate this somewhat complex motor activity, but you could probably all do this. This boy, watch how he tries to do this. Remember, she's just using one hand. So imagine if it's a more essential activity than just imitation. So, and he's not weak. Now we're going to go to the second one.
I don't have it.
If we don't have it, we won't do it. Okay, I'll do my slides. Okay.
Go away.
Go away.
Don't go away. Okay.
So we're going to want to. Oh, it is all blown up. Okay, good. These are some of the more common neurologic problems that you've heard about or not. So most common, attention deficit disorder. And I'm looking around the room. I'm not sure if any of you have it, you're controlling it. So yeah, 10%. I mean, my goodness. Sometimes manifests with hyperactivity. Other times just trouble hanging on to one thought at a time. This can actually be pretty productive for you if you're not in school. So once you get beyond sitting in a classroom and having to do exactly what you're told, and you can multitask wonderfully. But if you're, but ADHD. Dyspraxia, second most common on this list. Learning disabilities in general. And by learning disorder, we're talking about somebody with normal intelligence, So if you do the neuropsychologic test and do an IQ test, their IQ is going to be in the very normal range. Could be at the top, could be in the middle, could be at the bottom. But they're having trouble reading, for example. That would be dyslexia. 8%. Autism, which we hear so much about and have become directly, we used to think this was 1 in 10,000 children. And it's, I don't know sensitivities here, I don't believe this is an epidemic, it's not catching, it's not, but we're now recognizing that so many people are on the autism spectrum, and they really are, and they need special services. Intellectual disability, we used to call mental retardation, less than 2%, epilepsy 1%, cerebral palsy 0.2%. Many of these conditions that we call conditions, so there's a lot of overlap here, come with associated behavior, anxiety, and depression issues. These percentages are of the general population of children. When you get into these disorders, when you can look at it, they associate. So for example, the best data I have is in autism, where about 40% of children who have autism also have a defined mental health comorbidity along with it. So this is what we're looking at. The data I'm using, 1 in 6 children have such a disability, one of these disabilities. Now, in a given family, often the average is 2 children. So chances are 1 in 3 families will have a child, at least one child, with one of these disorders. This is very common. We heard the statistics earlier. More common and more costly because of the lifespan than these diseases, Parkinson's, Alzheimer's, and stroke that you hear so much about and that we're so concerned about, all of us. But this is another breed of childhood disorders that often are with you for a lifetime. And so this is, our institute is dedicated to these children. Last year we saw 24,000 families who have a child with one of these problems or more rare conditions. And they come from every state in the country and many, many countries. So I'm not going to get deep into the science, but what do we think, what can we do today that we couldn't do 5 years ago? Well, because of Google and Amazon and computers in general and memory storage, we can collect and analyze an enormous amount of data. So we can, you're telling us about all the neuropsychologic data you have. Well, we could, that's all numbers, pretty much. We could have, not only we have 10,000 children that we have the same kind of data over time. And it's an enormous number of data points, but we can, it's not, when we talk to like the astronomers who are, looking at billions of stars and billions of galaxies, it's trivial. The numbers are small given what you can really get your hands around. We feel collecting that information is part of the ability to make progress in the future. We want to be able to look at each child separately and be able to find other children just like that child, and then be able to explore them as a group under what is the underlying etiology of this problem. So often this runs in families, and that sort of tells you there's a genetic component to this and a gene to be found. Now, why do you want to know that? It isn't just for risk assessment. There may be a clue then for therapy and or modifying this, however you might approach it. And actually, the activity of your genes changes even with special education. So it isn't like the therapy has to be a drug. It can be behavior therapy, it can be educational therapy. This is what you were hearing about. Here's all the issues. I'm not going to, aggression, low self-esteem, low muscle tone. These are the kind of issues that children have. And if we're going to focus in and understand children, a specific child, we want to find 100 or 1,000 who look just like that child. And what are we going to do next? At least in one case, we will be looking at all of their genes. I'm not going to explain how you do that, it's another talk. But we can, now for a few $100 on a research basis, you can get a full genome on anybody. The goal is to figure out what's causing these problems and what we can do to treat them And we do have the sense that the earlier the better. But I'm also convinced that you can reopen these critical times of brain. It's so easy to learn a language when you're 2 years old. You can learn any language, you're 2. It's much harder when you're 25 or 50. And so there's these windows of, can you reopen these windows so we can teach people who we didn't have a chance to work with when they were 2 years old. So our goal, in addition to developing treatments and interventions, is to shift this so we can get early prediction of who's at risk and then do something that is going to improve their outcome. And the something that you do is going to vary with the child and their conditions. I really believe this is the time. We have incredible tools, the imaging tools, genetic tools, the big data analysis, which is useful in all of medicine. So, here we are, here's the children. Earlier, more effective treatments are within reach. Brain research is moving faster than ever. And who's funding this? We're hearing some challenges with the pharmaceutical industry because they don't see the rapid return. But we're looking to the federal government. Mainly, who's funding this research? It is the NIH. It is the federal government that you influence. Congress actually influences what each institute can have in the way of funding, as well as the NIH as a whole. Several of the institutes, there's the Child Health Institute, there's the Mental Health Institute, there's the Neurologic Institute, there's the Environmental Health Sciences Institute, all of which are contributing to research, helping sponsor research that's going to be applicable to this. What we want from you is to be aware that we're certainly for curing Parkinson's disease. I worry about it. I worry about Alzheimer's disease, getting older. But
Me too.
1 in 6 children will have a lifetime that we can change. And we need support. The country, the researchers of the country. Johns Hopkins has 1,000 neuroscientists on its faculty. They're brilliant people, ready to go. And there's never enough money to do this research. Okay, so your support is the key to helping more children lead a productive life. And I'm happy to answer any questions. I didn't bring maps of the brain. We can image your brain, not just see what it looks like, we can see how it's interacting. And we see differences and we see changes in how the brain is behaving after a child has had a bad emotional experience. So we have a clinic for children who we call it traumatic stress. These are children who may live in a violent community. They may have had an experience of abuse or just witnessing violence and being scared all the time. When you image their brains, not just how the brain looks, but how it's connected, you see differences. And then we begin therapy, like you're talking about, and we see that therapy not only helping the child with time, we see their brain changing.
Yeah.
So this is really physical. And it gives us clues, well, what's the best therapy? Because their brain changes before their behavior improves. You know you're on the right track. It's like radiating that tumor and you see it getting smaller before you're feeling better. You know you're moving in the right direction. So we can do that. The brain, the heart's really complicated, but easier than cancer. Cancer, tough, easier than the brain. But we're there. The genes make a difference. The data makes a difference. Our incredible imaging tools make a difference. And everything we do, our budget for research is 85% from the NIH. And it scares me when I hear that they're cutting, there was a proposal, I don't know why you stand on this, but there was a proposal to cut the NIH budget by 1/3. And how could you, it never happened before. No, it didn't happen. Why didn't it happen? Because I think the people in Congress, 1 in 3 families, they're not going to let, why would you not want to expand this? So that's the message to bring home to your people who can make the decisions. I thank you, and I'm happy to.
Let's go ahead and ask any questions of our panelists, including, I think, Griffin would even take some questions too.
He would like some questions. I can
He would
tell.
like some questions
So start with-
too. So Dr. Goldstein, do you want me to get you a chair, or do you want to just
No, I'm
stay?
fine.
You're fine, okay.
I'll start because everybody's being shy.
Yes.
One of the things that came through loud and clear in all the presentations was the need for early diagnosis, or the benefits of early diagnosis. Are there things that can be done to assure that diagnosis happens at an earlier time?
So you can be in, one, you want to look for what are the markers of these problems early.
Mm-hmm.
Like, strangely, we've learned that motor development is different in infants who will have autism. So we're not looking at their social interaction at that point, which is the essence of autism. We're looking at motor skills. And what we have to understand in a disorder like this, looking at the youngest children, what do they look like? So the pediatrician can recognize that and know that this child's at risk. I don't think we're going to start by doing genomes on everybody. That's
right.
Hopefully for the distant future. But what we will be doing is well baby exams. And we have to know how to look, not just to see how much the baby weighs and
Yeah, the
how long they
pediatricians have no
are.
clue on this one.
That's what I was-
Well, that's always been, I'm a pediatrician, but that's
Except for
always
him.
been.
I'm gonna give him a pass.
Yeah. That was the biggest complaint we get from parents. The parent says, I knew something was really wrong. And the pediatrician, don't worry, come back in 6 months, they'll outgrow it. And I don't hear that much anymore. It is better. It is better in the last 5 years than it was. They wouldn't even refer to us. I mean, the parents would do self-referral because they wanted help. And the doctors were not buying into this yet. Let alone the teachers in the school system.
Well,
all the things you're talking about.
For us, I'm sure every scenario is different. Griffin did cross midline at one point. We know this because he crawled. That's a pretty big crossing midline activity that one has to do to organize your limbs. It's where sometimes when you were learning to write and you had to cross a T and you would go to one side and then you would meet it in the middle. Literally, it's crossing. He wouldn't call the way across a T. He would go to the center point of the line and then go to the line like that.
I would.
So that was one way that we noticed. And then the other thing that we noticed is his teacher actually noticed, his preschool teacher, that he wouldn't pick a dominant hand. He would use both of his hands. And it's interesting because at USC right now, they're doing a study and we wanted to be involved, but they said no because we need everyone to be right hand dominant. And I was like, well, then it's not really a study on dyspraxia now, is it? That was the big clue for us. And the other thing is we would say to his teachers, well, he said he doesn't like to write or cut with scissors. And for a while they fell for it because he was such a good storyteller. They would ask him to write something and he would say, no, but let me tell you about this. And it was like, look at the monkey. And then they kind of would, because he was great at telling stories. But eventually, we learned that cutting with scissors was difficult. Even to this day, he is left-handed when he writes. He is left-handed when he eats. But his gross motor skills, such as throwing a ball or even cutting with scissors, needs to be done with his right hand.
And you can imagine the child I showed you trying to use scissors. And how do we learn? You imitate people. And he would just try. I have another video of him, which we didn't have here, just mimicking erasing a blackboard. And so you just have to go like that. But this boy's all over the place. Both hands are moving. He doesn't get to do that. But yet, intellectually, the rest of the systems are working. And his arms are not weak. It is that he can't lift his arm and do that. But yeah.
I don't want to open up a can of worms, but with both of our sons going through different types of diagnosis, we had the gold standard we resided in Illinois when this was happening. We had the gold standard policies for insurance. Nobody would see them. We had to pay self-fund just to get them to look at it. It was averaging $7,000 to $10,000 just for the neuropsych exam, just to get the schools to even consider giving them the support. That's another one of our problems is trying to refer children with the diagnosis, but even getting the diagnosis when the insurance companies are fighting it. I mean, my God, even my son, and I get choked up when I talk about leukemia, we had to sue an insurance company because they claimed pre-existing condition on our son for leukemia at 2 years old. So, we just have to realize at the federal level that it needs to be recognized and it needs to be covered. So that's.
Yeah, you know, in other countries, you say dyspraxia, they know exactly what you're talking about. It's like dyslexia here. They know what that means. And here I said, and they're like, oh, interesting, what is that? You know, it's really, it's something that affects so many people, yet not many people know about it.
Right. There's a question right here.
Thank you. I'd like to start by thanking all four of you for coming and being advocates for something that is a little more difficult to talk about, and for shedding light on something that's really not common knowledge. But on to my questions. Baker, I know that you had mentioned that when Griffin was diagnosed, you were talking, I guess, with school administrators, trying to get him an IEP, and that dyspraxia wasn't listed as one of the disorders covered. Has that been fixed, or is that still not covered on a lot of IEPs?
That has not been fixed. It was literally a showdown that I just won.
Nor in Illinois.
Nor
Yeah.
in
Chicago.
Nor in Montgomery County, over in Maryland.
They will say, well, can we qualify him on ADHD?
Yep, exactly.
Because sometimes children with dyspraxia, it can look like ADD or ADHD, simply because, you know, think about it. If you have to consciously think to really sit your body upright and do a math problem at the same time and listen to someone talking, it's a lot to think about, right? They're actually pretty amazing people that they can manage that. I can't do anything when I'm doing math other than just do the problem, you know? So, they wanted to maybe qualify him in that. And, you know, I said, look, I need it to be under this. So there is a blanket, other health impairment. He had the symptoms of almost all of them, you know, but it needs to say dyspraxia. We need that to be changed.
Well, in our case, if he was given a prescription, it would help. And we did it for a short period of time, and it wasn't for him until we found an environment in upstate New York where medication is certainly an important component to some of these conditions, but it was more environment and the tools. So
The environment is, and the behavioral therapy, he says, you know, it can grow neurons in your brain. It is actually so effective. And another thing I want to just mention with dyspraxia is that there's often a really poor immune system or an overtaxed central nervous system. So drugs is not an option for us. It has terrible consequences for us. It's just not on the table for us. And so, unfortunately, because that part can't be monetized, people don't want to pay attention. You know? Yes?
Dr. Goldstein, do you have any sense of how much investment the federal government's making in dyspraxia research?
Oh, I think it's a topic. I'd be surprised if it's $100,000.
30 million people. I did not know.
Yeah. I mean, autism was that way. And then they sort of claim, well, it's incorporated in all this other stuff. But with a lot of advocacy and persistent people, parents, not scientists, it changed. Still isn't what they want, but.
And I will say, too, that there's different levels of severity. I've seen videos of children in the UK with dyspraxia that really cannot make it across the room without falling over. And then there are others where it just sneaks up on you, and it's like, oh, he fell. You know, that was the other thing with us. There were lots of falls. You know, and as soon as I explained to Griffin what it was a big weight off of his shoulders, honestly, to go, oh, thank you. There is something there. And I questioned it in myself. I mean, if you want to watch a comedy routine, you won't set up a camera and watch me cook something, because I'm going to drop, I'm going to spill, I'm going to misjudge. I checked the recipe 50 times, convinced that I'm going to screw it up. So, you know, the thing that I kind of love about dyspraxia that's so fascinating is that, you know, it's described as immature neurons in certain areas. So no one's neurons are perfect in every area. So there is some component that everyone can relate to in it.
So I have a question. What are the unique differences between children with dyspraxia and then adults with dyspraxia? So I know that it doesn't go away.
Okay, so, well, does it? Or, I mean, it's not something that goes away, but, you know, at the same time, what is this I'm always saying? The brain is elastic, it's pliable, you can build new neurons, it will find a way. So, you know, tell me it's not, you know. The thing with life is that there are new skills in your face every day, right? So you may learn to catch and throw a ball, but then, you know, the ball size changes, or the game changes, or someone throws it away that person didn't throw it. Or even in human interactions, you know, you can use behavioral therapy to go over certain things, but you meet a different person, they're going to have a different answer for you. So life is constantly on the move. So once one skill is learned, there's always more skills to be learned.
You develop strategies as you get older, and most people play to their skills.
Sure.
So if you are not in school, you don't have any. It's everything. So the things you're not doing well really, really stand out and bother you. When you get to be an adult, you're not going to be. You know, if you have autism and you're not social, you're not going to be a salesman. I mean, you just can't train someone like that to be a salesman. But you could be a trader.
Well, coming from our son is now 20. We've watched the evolution, and thank God he was in an environment where they gave him the tools to recognize his weaknesses and ways to cope, and he does that. He's 20 now, so that's that age where I don't really have this condition, and I'm going to try it on my own. Well, he's realizing, and he's coming to terms with there was a reason for where he was out in New York, and he's doing better, but he's still struggling. He'll struggle the rest of his life. It's more about adapting than anything, and at least from my perspective. So.
A question for Griffin. Griffin, what kinds of things do you work on with like your speech therapist or occupational therapist or whoever's on there?
When you work with Maria, why don't you tell him what you do?
I have an occupational therapist, and I practice working out.
Mm-hmm. What's your favorite activity that you do?
Playing.
Playing. That's a good occupational therapist because he thinks he's playing, but she's building your muscles, right?
Yeah, I have to throw like this. There's this really big ball. It's like maybe 5 or 6 pounds, and I have to throw it into the air, and I can do that.
But when he first started, these water bottles, to do this was difficult. So not only is the strength improved, but there's coordination with all of this. There's sensory exploration with it. She's really on top of it. And interestingly enough, our occupational therapist specializes in something called norepinephrine, and it was more on, she learned more about stroke victims. And she has proven to be our best occupational therapist because of her understanding of the brain.
Can I tell them what I work on in speech?
Sure.
So I do speech at my school, and the speech teacher's name is Miss Gina, I think. Yeah. And I work on summarizing stories.
Right. So as you can tell, his speech is pretty awesome, right? But speech isn't just what comes out of your mouth. It's also receptive language and repeating stories that you're told. So one thing that Griffin likes to do is he likes to, like my friend said to me that we just visited, wow, he really likes to repeat that story. But he's practicing that story to get the sequencing of that story down, to make sure, wait, did I leave out a part when you learn a song, well, I don't know if you're a singer. You strike me as a singer, so. So, when I imagine you showering, singing the song. Sometimes if you don't get it right, you back up and you go over it. That's kind of how he does with telling stories, too, so that he sequences that properly. He's getting pretty good at it, too.
So, my son, as far as the dexterity and the physical side of this, he naturally had an inclination towards music. And he plays like 14 instruments, and I didn't even, these are the moments, I didn't even realize it till sitting here today. That's where he started benefiting his dexterity, his strength, his guitar work, his piano work. That was all helping him. His body was telling him what he needed to do. And, music has done that for him. Otherwise, he is a rail. I mean, his brothers side by side, one looks like he is doing tough letters, and this guy, he's all veiny in the arms from playing instruments, but thank God, because I think things could be far worse.
Yeah, they say sometimes with dyspraxia they don't have rhythm. Griffin is quite the opposite. He is completely moved by music. And I got an email in the middle of the day the other day, and usually it's, oh, who fell, right? That's usually, but it was from his music teacher and Mrs. G saying, oh my goodness, Griffin got up in class today, and he sang, and he was so good. He was pitch perfect, and he was very expressive, and he hit all the notes, and now they're like, you should get him into music. So actually, you know, that music gets that brain pathway to really go and really work. It can be inspiring and get your fingers moving where they normally wouldn't.
Thank you.
Great. I'm just gonna come up and
One
thank
more
you
over
all.
here. We have one more.
Oh, one more question,
I have
good.
a science question. Well, and thank you guys. I mean, I actually,
I'm not
I'll be
going up
honest
there.
with you, and I run a patient organization, and this is one of my parents, and she goes, she goes, oh yes, I'm coming to this because our children, I'd never heard of it before. And so I appreciate the overview, because I was going to ask, have there been, it sounds like obviously it's a spectrum, so there could be many different genes involved. So have they identified any particular?
You can't answer that, 'cause I don't think any genetic studies have been done on this condition.
Because I was
Now,
going
you
to say,
can't look at the children who have autism and this condition, because then you're gonna get confused by the autism. You have to find children who do not have the other problems, test them, and so they're pure. Then you need 100 of them, you need 100 controls, or whatever it would be, and then you might find either risk genes or causative genes. And I don't, to my knowledge, just because of the lack of recognition, this hasn't been done. And that's not such a difficult experiment to do.
Well, I love the question because it brought a subject matter up that I haven't discussed in a long time. Because our youngest son had leukemia, when we decided to have a second child, we saved the cord blood.
I'm glad you bring this up. It's on my
So we
to-do
have
list.
that stored in cryogenics, and it's interesting. So then Trey, excuse me, I didn't want to mention his name, my youngest son with dyspraxia, you know, we're all in to help others. So there's the beginnings right there. And that's medical waste that's gone right into the can. And it could be saved in, you know, from a scientific standpoint.
So we have the cord blood too, and they won't let me have it because it's not on their list of something that can be used for. So, I'm gonna get it.
I'd hate to be the one stopping.
I see it breaking.
and the story that she said, you know, when you read every symptom, we were looking at each other because that is our kids to
Well, my daughter has global dyspraxia, but she also has this other syndrome, SYNGAP syndrome. So it's
when she
remarkable
says-
to see a child that is my kid.
When she says global dyspraxia, she means that the speech is also affected. That's what global dyspraxia is.
Any other questions?